Hello, Rebecca Basham here again, founder and creator of all things PAC. So I'm a PA. I've been a practicing PA for over 14 years. I've worked in emergency medicine, family medicine, academia, and one of my passions is creating resources for PA students to help them succeed in school and to pass their boards. My company, All Things PAC, has several products available, including our All Things PAC QBank. We have a bullet point style digital review course called PANCE Points, and we're currently in the process of making a video review course, of which these videos are part of that. We're offering those to you for free now. And we're going to go ahead and get started today. Today's video is over congenital heart diseases. We're going to cover those CHDs that are on the PANCE blueprint that are listed here, and we're going to go over them each individually. We're going to do some practice questions. We're going to give you some rapid fire. We're going to have a good time. So let's get started. All right, I like to start these reviews by giving you a couple of practice questions. And so what I'm going to do is I'm going to put a few questions up one at a time. You may need to stop the video to give yourself time to read it. And it's sort of kind of a pre-review check, sort of check your knowledge. Do you know the answer off the top of your head? Can you narrow it down to one or two? Do you think you know the answer, but you're not super confident? And then after the review, we'll look at the questions again and we'll go over the answers and explanations together. So here in a second, I'm going to put the questions up, and remember, you might need to pause the video to give yourself time to read it. Here we go. All right, guys, before we go over each individual congenital heart defect, I want to start with just some basic background information and physiology that I think will be helpful as we look at the individual defects. So first, what is a congenital heart defect? So essentially, these occur from abnormal embryonic development of the cardiac structure. So while the embryo is developing, there is abnormal development of either the valves, the vessels, the walls of the heart, etc. Now, these defects can be small and not really cause a lot of problems or be asymptomatic, or they can be life-threatening from birth. It just depends on the severity and the type of defect. Now, if you remember some basic physiology, it's important to remember that blood is always going to flow from an area higher pressure to lower pressure, right? That's just basic physics. So if these connections are abnormal, whether there's a defect in the wall of the heart or a valve issue, it can create dysfunction that can lead to things like volume overload, pressure overload, and even cyanosis if oxygen is unable to be circulated. Now, we usually classify defects as being either acyanotic or cyanotic. So, acyanotic defects involve a left to right shunt. So, because the left side of the heart is normally at a higher pressure than the right side, oxygenated blood from the systemic circulation, so either the left atrium or the left ventricle, is pushed to the right side. And because it's oxygenated, patients don't become cyanotic, but they can develop things like volume overload. Now, cyanotic defects usually involve a right to left shunt. So, in these situations, deoxygenated blood bypasses the lungs and enters circulation without adequate oxygen to supply the body. So, these are often going to present very early. So, these infants present early and they're cyanotic. And that cyanosis actually doesn't improve with oxygen administration. That's kind of a key feature of it. And that makes sense because oxygen availability really isn't the issue. Now, sometimes, and this will probably make more sense after we look at the individual defects, but sometimes you can have a cyanotic heart defect with another defect that allows for oxygenated and deoxygenated blood to mix. So, an example of this would be transposition of the great arteries. So, this is a cyanotic heart defect that's not compatible with life unless there is another defect like a PDA or an ASD or a VSD that allows for oxygenated blood and deoxygenated blood from the right and left side of the heart to mix and then circulate that systemically. So, again, if it doesn't have one of those defects along with it, transposition of the great arteries, there are two pulmonary circuits that are completely separate and it's not compatible with life. But if it's there with another defect that allows for the mixing, it's compatible with life, at least until repair in many cases. And again, that may make more sense as we look at the individual defects. And we're going to do that right now, starting with ASD. All right, an atrial septal defect or an ASD is a congenital communication between the right and left atria. Essentially, it's a hole in the wall, in the septal wall between the two atria. This is an acyanotic lesion because remember, there's higher pressure on the left side, so oxygenated blood is shunted from the left side to the right side. Now, what can happen is because there's increased volume in the right atria from the excess blood shunting over, is pulmonary overcirculation. So, which over time long term, can lead to pulmonary hypertension, right-sided heart failure, arrhythmias, things like that. Now, clinically, these may be asymptomatic at birth, but if missed, they may present in a child or as they get older with exercise intolerance, or one pearl is frequent respiratory infections. You might ask, like, well, why does that happen? Well, the extra blood flow increases pressure and blood flow in the pulmonary vessels of the lungs, so it creates this wet environment that makes the lungs more vulnerable and prone to infections. There's also risk of something called a paradoxical emboli. So, this happens when a blood clot from the venous system crosses from the right side through the defect, so through the ASD, it can even happen with a PFO, into the left side of the heart, and then from there enters arterial circulation. So, normally a venous clot goes to the lungs, and that's a pulmonary embolism. But if there's a defect or hole present, the clot can kind of bypass the lungs and go directly to the left side and then enter systemic circulation or any arterial circulation and cause a stroke or an MI. So, kind of a key pearl there, or PANCE pearl, is think paradoxical emboli, and if it's a young patient and an unexplained or cryptogenic stroke and has an ASD or a PFO that's found. The murmur of an ASD is a soft systolic murmur at the left upper sternal border, and it's caused from increased pulmonic flow. So the murmur you hear isn't actually the hole itself. It's from that increased flow across the pulmonic valve, and that's why it's a soft systolic murmur and heard best at the left upper sternal border. The other classic finding is a second heart sound. So normally the two components of S2, aortic and pulmonic valve closure, move closer together with exhalation and then further apart with inhalation. But in an ASD, because the right ventricle is always overfilled, the pulmonic valve closure is always delayed. So the split S2 doesn't vary with breathing, and that's why it's called a fixed split S2. As far as management, a lot of these will close on their own, but large or symptomatic defects may require surgical closure. All right, our next defect is coarctation of the aorta, or coarc for short. And this is a congenital narrowing of the aortic lumen. It's usually just distal to the origin of the left subclavian artery near the ductus arteriosus, just like you can see in that graphic there. This obstruction can cause increased afterload. So if you remember, afterload is basically resistance. And what it does is it causes upper body hypertension and then lower body hypoperfusion. Something else of note is that the body can actually create these collateral vessels over time to try and help compensate, and these are often in the form of multiple intercostal arteries. The classic presentation is absent or delayed femoral pulses, or in adults, hypertension in the upper extremities and then lower pressure in the lower extremities. Now, when a PDA is present, so patent ductus arteriosus, for a few days after birth, what happens is some oxygenated blood can bypass the obstruction and enter systemic circulation. And then when that PDA closes, if the coarc or obstruction is severe, the infant will then develop heart failure. So we're good for a few days until that PDA closes, and all of a sudden they have symptoms. There are also other symptoms that really just depend on the severity of the obstruction. You may hear a murmur, but it will also depend on the severity of the obstruction. The hallmark murmur is a harsh systolic ejection murmur, and it's caused by turbulent blood flow through the narrowed section of that aorta that's notched. And the most classic finding about this murmur is that it's best heard on the back, specifically over the left interscapular region between the shoulder blades. A few other pearls you may see. The chest x-ray can show this rib notching, and that's from those collateral vessels we talked about. Or you might see a 3 sign on a chest x-ray, and that's from the actual shape of the aorta with the notching. Treatment is going to be based on the severity. So things like the pressure gradient, high pressure gradient, excessive collateral vessels, and then of course systemic symptoms like hypertension, severe hypertension, heart failure, etc., things like that. And this is usually a surgical repair when repaired. Okay, on to our next defect, which is patent ductus arteriosus, or PDA. Now, if you remember in the developing fetus, the lungs are fluid filled, so they're not yet involved in gas exchange. Oxygenation comes from the placenta. The ductus arteriosus is a vascular connection between the pulmonary artery and the descending aorta, which allows oxygenated blood to bypass the lungs. So blood goes from the right ventricle into the pulmonary artery, then it's diverted through the ductus arteriosus into the aorta, and then onto systemic circulation in the placenta. And you can see in the graphic below that little connection, the PDA. It's supposed to close after birth when the baby starts breathing. Oxygen triggers this closure. Something else that triggers closure is decreased prostaglandin levels. Prostaglandins are what keep the PDA open during fetal development. After birth, the placenta is lost and the prostaglandin levels go down, and this allows the ductus arteriosus to close. So a patent PDA is just when this bypass remains open after birth. Now, remember, there are some situations where you want to intentionally keep the PDA open. If you have a cyanotic defect, having a PDA could be a temporary solution for oxygenating blood until the larger defect can be repaired. What they can do is give prostaglandins in order to keep it open. Now, on the contrary, NSAIDs, if you remember nonsteroidal anti-inflammatory drugs, inhibit prostaglandins. So they can actually give NSAIDs like indomethacin to preterm infants, for example, in order to close the PDA. A PDA by itself is an acyanotic lesion because the aortic pressure is greater than the pulmonary artery pressure, so you have another left to right shunt. As far as presentation, these infants may have tachypnea, poor feeding, or failure to thrive. On exam, you may find bounding peripheral pulses and a wide pulse pressure. The murmur is a continuous murmur heard below the left clavicle where the PDA is. And you hear this because aortic pressure is always higher than pulmonary artery pressure, so blood continuously flows from the aorta into the pulmonary artery. This abnormal high velocity flow creates turbulence, and that's the murmur that we're hearing. It's heard through both systole and diastole because the pressure gradient exists throughout the entire cardiac cycle. And then management, as mentioned before, indomethacin or sometimes surgical ligation for large symptomatic defects. Our next lesion is a patent foramen ovale or a PFO. So the foramen ovale is a small opening in the intraatrial septum, and like the ductus arteriosus, it's a normal structure of fetal development. It also, like the ductus arteriosus, allows oxygenated blood to bypass the lungs during fetal development, and like a PDA, it normally closes after birth. So when it remains open, it's considered a patent foramen ovale. The features of a PFO are going to sound familiar because it serves a similar purpose to a PDA, and it also very much resembles an atrial septal defect. Remember, an atrial septal defect is a hole between the two atria. So you may be wondering, what's the difference? Well, just remember, a PFO is a normal part of fetal development, and structurally, it's more of a flap-like tunnel, where an ASD is always considered structurally abnormal, and it's usually more of a hole and bigger than a PFO. After birth, when the lungs and pulmonary circulation become functional, pressure in the left atrium closes or collapses the PFO flap, usually within a few hours or days of birth. If left open or patent, this may become an acyanotic lesion, which you understand by now is because left-sided pressure is greater than right side, so pressure closes the flap or may push a little bit of oxygenated blood to the right side. However, in some situations, you can get a transient right to left shunt if the right atrial pressure increases. So, for example, Valsalva, coughing, straining, etc. But these situations are usually going to be transient and short lived. So, for the most part, these don't cause an issue. Even for those with a PFO, they will usually close by age 3. For PFOs that persist into adulthood, this does pose a risk for cryptogenic stroke, just like with an ASD. Remember, that's when a venous thromboembolism that makes its way to the heart bypasses the lungs, where it would typically be trapped as a PE, and instead travels through the defect into the left side of the heart, where it can directly enter systemic circulation and cause a stroke. Adults that have concern for a cryptogenic stroke should have an echocardiogram to look for an ASD or a PFO. They actually do something called a bubble study where they inject a solution with tiny bubbles and on the echocardiogram see if it travels across the atria through the defect. And if present, it may require intervention for closure. Now, as far as a murmur, the interesting thing here is there usually isn't one. And if you think about it, that makes sense because the sound of a murmur comes from turbulent blood flow, right? So since this is more of a flap that closes or collapses under pressure, left atrial pressure, there's no turbulent blood flow across a pressure gradient. In fact, if you hear a murmur in this area, you should think ASD over PFO. And as mentioned before, these usually close in infancy or childhood, but if they persist into adulthood and there's a risk or presence of cryptogenic stroke, they may require intervention. Okay, our next congenital heart defect is Tetralogy of Fallot. And this is certainly one of the more complicated ones that we've talked about or reviewed yet, and it's our first cyanotic lesion. So we'll cover all the high yield information you need to know. First of all, this is actually 4 defects that occur together, which is where the name tetralogy comes from. These 4 lesions, and I would encourage you to look at the graphic as I describe them, include first, ventricular septal defect or VSD, a right ventricular outflow obstruction or pulmonic stenosis, An overriding aorta, which is where the aorta sits not only above both ventricles, but above the VSD, where it receives blood from both ventricles, so both oxygenated and deoxygenated. And then finally, right ventricular hypertrophy, which is caused from pressure overload. Now, I know this is a lot to take in, but one of the most important things to remember here is the defects created cause cyanosis, which is what makes this condition so severe. And let's talk about why. The key is right ventricular outflow obstruction or pulmonic stenosis. Because the path from the right ventricle to the lungs is narrowed, blood looks for an easier route. The easier route is across the VSD into the left ventricle. So this means deoxygenated blood from the right ventricle mixes into systemic circulation instead of going to the lungs for oxygen first. And so the result is a right to left shunt where deoxygenated blood enters the aorta and causes cyanosis. Now, the presentation is going to depend on the degree of cyanosis, which is going to depend on the severity of these defects. One of the classic presentations in Tetralogy of Fallot is something called Tet Spells. And this is where right-sided pressure increases during things like crying or sometimes feeding or other situations that cause Valsalva, which cause worsening cyanosis or these spells during these events. A lot of these infants are diagnosed at or shortly after birth when they start to show signs and symptoms of cyanosis, and then a murmur is heard. The classic murmur is a crescendo decrescendo murmur with a harsh ejection quality at the left upper sternal border, which is the sound created by the pulmonic stenosis. And as management, these infants end up requiring surgical repair, usually within the first year of life. All right, next we have another serious cyanotic lesion, and that is transposition of the great vessels or transposition of the great arteries. And this is where the pulmonary artery and the aorta are transposed or switched. So the aorta arises from the right ventricle instead of the left, and the pulmonary artery arises from the left ventricle instead of the right. And what this creates is two parallel circulations instead of running together in series, they run independently. So the right ventricle pumps deoxygenated blood from the body right back through the aorta into systemic circulation again. And at the same time, the left ventricle pumps oxygenated blood it receives through the pulmonary artery right back to the lungs. But the oxygenated blood just stays on the left side of the heart, and the deoxygenated blood just keeps circulating throughout the body and back to the heart, but never makes it to the lungs to get oxygenated. And this is obviously not compatible with life unless there is a way to shunt oxygenated blood into the right ventricle, so an ASD, a VSD, or a PDA. These infants will present with cyanosis within the first hours or days of life, and the cyanosis does not respond to supplemental oxygen because we've talked about this before. Lack of oxygen isn't the problem. This is essentially a plumbing problem. Other signs and symptoms include tachypnea, poor feeding, and signs of heart failure from pulmonary circulation overload. Now, as far as a murmur, there may not be one present unless a VSD is also present, where you would hear the VSD murmur, and that's a systolic murmur at the left sternal border. Management here is surgical. Ultimately, the fix is an arterial switch procedure where they just switch the pulmonary artery and the aorta and put them where they're supposed to go. However, depending on the severity of the condition and if there's a shunt present at birth, they may need prostaglandins to keep the ductus arteriosus open or a septostomy performed to allow, basically, they put in a shunt to allow for mixing of oxygenated and deoxygenated blood until the repair can be performed. And our last defect, at least the last one covered on NCCPA's blueprint, is ventricular septal defect or a VSD. Now, because I'm going in order according to the blueprint, which is really just alphabetical order, I'm covering VSD last, but by now you've heard this mentioned and know that it's an opening in the septal wall between the right and left ventricle. This is the most common congenital heart defect. Physiologically, it's another acyanotic lesion because, as we've discussed several times, left ventricular pressure is greater than right, so there is a left to right shunt. However, something to note here is that a VSD also increases pulmonary blood flow, which leads to volume overload in the left atrium and left ventricle. And over time, this can lead to pulmonary vascular remodeling and pulmonary hypertension, in which case the pressure on the right side increases, and you actually get a reversal here and a right to left shunt, which can result in cyanosis. This is something called Eisenmenger syndrome. As far as presentation, small VSDs are often asymptomatic and may be found incidentally by a murmur or on a cardiac study for another reason. Large VSDs, though, can cause tachypnea, poor feeding, failure to thrive, recurrent respiratory infection in infancy. Remember, that's from the wet lungs you see from increased pulmonary circulation, and some of the other symptoms we see with many of these congenital heart defects. The murmur is a harsh holosystolic murmur at the left sternal border, which is the sound of the turbulent blood flow across the defect. They may also have a thrill on palpation. Now, something to keep in mind about these murmurs, though, is that a smaller defect can sometimes have a louder murmur. And if you think about it, that makes sense because a larger opening is going to create less turbulence than a smaller opening. For management, small defects may close on their own, so if asymptomatic, they can likely be monitored. But large or symptomatic defects require medical management. And here we're talking about treatment for volume overload and heart failure, so things like diuretics and other pharmacotherapy, nutrition therapy, things like that. If there's a significant shunt, surgical closure may be needed to prevent progression to the Eisenmenger syndrome, which can cause irreversible pulmonary hypertension if not treated. All right, now that we've covered all the CHDs that are on the NCC PA PANCE blueprint, let's go back and post those practice questions and see how you do. So I give you those 3 questions at the beginning of the review. What I'm going to do now, I'm going to post them one at a time. So I'm going to post the first question. Go ahead and pause the video to make sure you have time to read the question. And then unpause it, and then the next slide will be the answer and explanation that we'll look at together. And we'll do that for each of the 3 questions. All right now I'm getting ready to post the first question. Here we go. Okay, and the correct answer is B, atrial septal defect. And if you remember, an ASD causes increased blood flow through the right heart, leading to a fixed, wide splitting of the second heart sound. The systolic ejection murmur at the left upper sternal border is due to an increased flow across the pulmonic valve. Aortic stenosis is not correct. First of all, this usually isn't a CHD, although you can have something called a bicuspid aortic valve that can lead to aortic stenosis later in life, and that's also typically a systolic murmur at the right upper sternal border that radiates to the neck. Coarctation is not the best answer. This usually presents with hypertension in the upper extremities with diminished femoral pulses, not a fixed S2. PDA, incorrect. This usually has a continuous murmur, not just a systolic murmur. And then VSD is not correct. That's usually a harsh holosystolic murmur at the left lower sternal border. Okay, moving along, here is question 2. Don't forget to pause to give yourself time to read the question. All right, correct answer here, B, coarctation of the aorta. So you remember coarc presents with upper extremity hypertension with delayed or diminished femoral pulses. That is the hallmark. And then lower extremity hypotension. The murmurs are often best heard over the back or the left infraclavicular area. So ASD is incorrect. This produces a soft systolic murmur with a fixed splitting S2, no blood pressure differences. A PDA produces a continuous murmur and bounding pulses, not pulse discrepancies. Tetralogy of Fallot is going to cause cyanosis and a harsh systolic murmur at the left upper sternal border, not hypertension with diminished femoral pulses. And then a VSD causes a harsh holosystolic murmur at the left lower sternal border and not, again, the difference in pulse pressures. Okay, last question I'm going to post now. Go ahead and give yourself time to read it, and then we'll go over the answer. All right, hopefully you got this last one correct. Tetralogy of Fallot, D. So Tetralogy of Fallot causes cyanotic episodes we call Tet Spells, which are typically triggered by exertion or crying, and these occur due to increased right to left shunting across the VSD as right ventricular outflow obstruction or that pulmonic stenosis worsens. I didn't talk about this in the review, but what you may see as listed in this vignette here is infants may instinctively assume this sort of knee-chest position to increase systemic vascular resistance, and that reduces shunting and improves oxygenation. So it's kind of a reflex. And if we look at why we can rule out our other answer choices, atrial septal defect is usually an acyanotic lesion, and it presents with a fixed splitting S2, not cyanotic spells. Coarc presents with hypertension in the arms and diminished femoral pulses, not acute cyanosis. PDA, again, that continuous murmur and bounding pulses, not paroxysmal cyanosis. And then a VSD is going to have that harsh holosystolic murmur. Maybe cyanotic, but typically that's in severe progressive disease with that Eisenmenger syndrome later. And again, not classically with the vignette presented here. All right, that's a wrap for congenital heart defects. I hope you found it helpful. And hey, if you did find it helpful, make sure you check out our website. We have tons of resources for PA students. A couple of them I'll mention here. We have a 20-question practice quiz that's totally free. This is a practice PANCE quiz. So you get 20 questions that look just like questions you'll see on the PANCE, comes complete with the answers and explanations. And if you like that, you can check out the products that we sell. We have some great affordable products. We have a 300 question digital download that's a full length mock practice PANCE exam. So 300 questions that also come complete with answers and explanations. And then we have a comprehensive QBank. This is a digital product subscription. So with that, you get access to our QBank, tons of questions. You can filter by body system, by EOR. You can take quizzes. You can take a practice exam. And those also give you answers and explanations. You also get a personalized dashboard so you can kind of keep track of your progress as you study. And then we also have something called PANCE Points, and that's sort of a companion to our QBank. And that is a bullet point style review of every topic on the NCC PANCE blueprint. Again, that's a digital product that comes along with our QBank. So just make sure you check out our website if you're looking for some good resources.